The RN that's going to be presenting STIs, stats, and updates for you today. I have nothing to disclose. The learning outcomes of this presentation, you will be able to verbalize the most common STIs in the United States, identify the groups most vulnerable for contracting an STI, and be able to list one or two updates for treatments of bacterial STIs such as gonorrhea, chlamydia, trichomoniasis, and syphilis. A little bit about my background. I was the college health nurse at AUM, Auburn University Montgomery, for over 20 years. My interest obviously is in STIs, also vaccines and travel medicine. I've been the PrEP and STI nurse coordinator at Medical Advocacy and Outreach at the Wellness Center for over a year at this time, and I have my STI clinic that I basically run 5 days a week. Okay. For STIs in the United States, it is an overview. It shows that 1.5 people in the United States have an STI, which in 2018 was nearly 68 million. There were 26 million new STIs in 2018, and nearly half of those new STIs were among the youth aged 15 to 24. The direct medical costs for STIs yearly is almost 16 billion, which is an astounding number, and it's something that we need to consider when we don't educate people and talk to people about their sexual health. These are the kinds of problems that we get into. Okay, I really like this slide because it simplifies incidence versus prevalence. I'm just going to read this off. Prevalence is the estimated number of infections, new or existing, in a given time, like for a year. An incidence is the estimated number of new infections, diagnosed or undiagnosed, say in January. So when you think about it, we'll see a high prevalence rate with viral infections because there's not a cure for those infections, but there's management. So the numbers of people affected by these conditions continue to rise. Incidence rates for bacterial infections are higher, but the prevalency rate over time will be lower because we can treat those types of STIs with an antibiotic. Okay, for the next slide, chlamydia in 2019. This is from the CDC, as most of my graphs are. This just shows the different county rates for STIs, and anything in the dark blue, which if you look really closely at Alabama, is a high rate, and that's typically, we see this usually in the black belt or area of Alabama. The next slide will discuss the rankings of chlamydia by the states. And as you can see, Mississippi, Louisiana, South Carolina, North Carolina, Georgia, Alabama were all in the top 10. Alaska is it's not an anomaly, it's just that there are less people there, so the case and the rate per population is higher. But it's important to note where Alabama is in those rankings. We are 8th, and that's pretty significant. Gonorrhea, we are also in a dark blue zone, which says that we have a very high rate of that as well. When we break it down by the state level, who ranks the highest, you'll see again it is another southern state with Mississippi. Alabama came in 3rd. Again, South Carolina, Louisiana, North Carolina, and Tennessee were all in there. All right, the next slide is going to show syphilis with primary and secondary in 2019. Alabama did a little bit better that particular year, but is still surrounded by the dark blue states. We've got Mississippi, we've got Georgia, Louisiana, and Florida with those with high incidence of or high rankings of syphilis for that particular year. And the reason why we're a couple of years behind, about 3 years behind on our numbers, is because it takes so long to get all of the data from the different states and the different, you have to get to the county level to prepare all this information. So what are the new updates to STI treatments from 2021? There will not be a lot of talk about specific conditions and populations like pregnancy or allergies. I'll make a couple of exceptions, but I do encourage all of you to download a copy of the full updates from the CDC. You can also order a hard copy from them, and there is also a real quick list, kind of checklist that you can go through. It's a little bit difficult to read because the print's so small, but it would be well worth it to have it in your clinics or your office settings. Okay, moving right along, I want to talk first about chlamydia. The 2015 guidelines said that we wanted to have azithromycin as our #1 go-to drug with 1 gram PO at one time to be given to patients because it was such a quick and easy fix. We could actually watch the patient take the medication in the clinic or the office setting and know that, you know, the majority of the time there's going to be a cure for it. Doxycycline was in second place there as the alternative to be taken 100 milligrams by mouth 2 times a day for 7 days. The new guidelines are more specific and they want to use doxycycline for 7 days, 2 times a day, so 14 count on the capsules or the tablets. The reason for that is studies are indicating that it is much more effective for people who have rectal or pharyngeal chlamydia, and you can still use azithromycin because you don't want to give doxycycline obviously to a pregnant woman. And I do recommend, if you're going to give doxycycline, do a urine pregnancy test before you administer it. Okay, the next one that we're going to go to is gonorrhea. The 2015 guidelines were actually updated in 2020, where the old recommendation, and a lot of people remember this, was the 250 milligrams of ceftriaxone or Rocephin, and then a side of the 1 gram azithromycin if chlamydia had not been excluded as a co-infection. The new guidelines are weight-based. It's a 500 milligram injection of Rocephin or ceftriaxone for people weighing under 300 pounds or about 150 kilograms, and it's 1 gram if they're over the 300 pounds. Again, if chlamydia has not been excluded, you want to give that doxycycline 100 milligrams BID for 7 days. Something that's real interesting, and I haven't mentioned it before, is that they are working currently on a vaccine for gonorrhea. UAB is experimenting with that in some clinical trials, and it does look very, very promising. So that's coming up, you know, down the pipe soon. All right, syphilis is very, very interesting to me. I've never seen so much of it until I actually started working here at MAO. And there's primary, secondary, and early latent, which we won't go into. I do want to mention that the treatment has been a little bit simplified. It's the same treatment that we have used in the past, but what has changed is the 2.4 million units of the benzathine penicillin in a single dose, where we used to give that dosage over, we would give it 1 week and then a second dose, the second week to pregnant women. It's been streamlined and they all get just that single dose. I do want you to know and be able to tell your patients that there is a thing called a Cherish Hexheimer reaction, and it's particular to that first dose of the antibiotic. what it is a reaction to the antibiotic killing off the spirochetes of the syphilis, and they set off an endotoxin which the immune system begins to react to. And some of the symptoms are fever, which is over 101, chills, you'll have tachycardia, some myalgia, some arthralgia, fatigue, headache, rash. And this usually occurs 4 to 6 hours after the injection and goes away within 24. And you do want to recommend Tylenol for that. Some more severe reactions are going to be some chest pain, some shortness of breath, for which your patient would want to go to the ER and be examined for. And I had to learn about this reaction the hard way, so please notify your patients if you're giving them the bicillin, so they can be aware that this is a very common reaction and what they need to do for it. In the syphilis late latent, that means that we don't really have a time frame as to when the patient may have been infected, but it's typically over a year. There's no change in the guidelines. We do give the 3 doses of 2.4 million units of bicillin, 1 dose a week for a total of 7.2 million units. If you've never given bicillin before, it is very thick. It comes in, the 2.4 comes in a 4 milliliter pre-drawn syringe. It's usually given with an 18 gauge needle, so it has to go in a very fatty part of the body. It is very painful injection. A lot of patients prefer to have the dose split to a 1.2, and then that can be given into the 2 glute areas. And that tends to be a little more tolerable for patients. There are many more recommendations in the guidelines for syphilis in regards to pregnant women and people who are living with HIV. It is still recommended, though, that a person with a true penicillin allergy be desensitized in the hospital in order to receive the optimal treatment of penicillin. A true penicillin allergy would be anaphylaxis, obviously, a rash, shortness of breath, or throat closing. What is not a true reaction is going to be a yeast infection or it made my stomach hurt. So keep that in mind when people say, oh, I had a reaction. Okay, moving on to the next slide. Trichomoniasis. It's very interesting. It's a parasitic infection. You can actually see it under the microscope. And according to the CDC, trich is considered the most prevalent non-viral STI worldwide. It is not a reportable infection, and the treatment guidelines changed this time when it was found that women who were retested for a cure 1 month after treatment, the 7-day treatment actually reduced the proportion of women retesting positive by half over women receiving the one-time 2-gram dosing, but there's no studies available for men. So in 2015, we used to just give the 2 grams or 4 of the 500 milligrams flagyl metrodiazole in 1 dose. Today, we're going to give males the 2 grams in 1 dose, and women are going to get it 500 milligrams 2 times a day for 7 days. And it can make them nauseous. It can make them a little sick to their stomach. It has been disproven that they can drink alcohol while they're on this. That apparently was not substantiated, and the current literature says that they can drink alcohol. But I always just tell patients to be careful when they're drinking any kind of alcohol and, on any antibiotics. The next one is, we're going to change gears just for a moment, and we're going to look at herpes or HSV. And this is particularly for the first episode. The only thing that has changed is that the second on the 2015 guidelines, the acyclovir 200 milligrams 5 times a day for 7 to 10 days, was taken out just because it's not very feasible for most people to take a pill 5 times a day. It is still a recommendation, but because of the frequency, we don't recommend it. And when you look at the pricing for like acyclovir 3 times a day for 7 to 10 days, it's typically, if you look at GoodRx and your patient doesn't have insurance, it's going to be about $7, $8 for the acyclovir versus $20 for valcyclovir. And the benefit with the valcyclovir is they only have to take it 2 times a day. So that might be something to consider for your patient. I know it's difficult for me to take a medicine in the middle of the day just because I don't think about it. It's not a habit for me. So, it's not going to be one for a lot of patients either. So that might be a little difficult. Okay, non-gonococcal urethritis, going back to a bacterial infection. We really don't know what causes it. We think it's a strain of chlamydia. And in 2015, the recommended dose for males obviously was going to be the azithromycin 1 gram in 1 dose. And then doxycycline was the backup if we wanted to do that 2 times a day for 7 days. Now the recommendation is the doxycycline 100 milligrams orally twice a day for 7 days, where the azithromycin is the second recommendation. The reason it has changed is, again, we found it is much more effective to use the doxycycline, and with males, obviously, you don't have to worry about pregnancy or anything like that. Had a little brain thing that went on there, but yeah, they don't have to worry about pregnancy. Okay, with the next one, pelvic inflammatory disease, the only real change is at the very top. We used to just give people a choice, or we didn't give them a choice. We made the choice for them whether or not we were going to dispense the metrodiazole twice a day for 14 days. So it's going to be the ceftriaxone, the Rocephin injection, 250 milligrams, plus doxycycline, and then with or without the flagell. Now the flagell, the metrodiazole, is part of the recommendation for outpatient pelvic inflammatory disease. The ceftriaxone has changed where it is weight-based. Again, you want to make sure that you're giving at least 500 milligrams IM. If they weigh less than 300 pounds, over 300 pounds, you want to give a full gram. So that's something to keep in mind. All right, there we go. Bacterial vaginosis is very interesting to me. It is not a true STI, but it does affect millions of women. It's not reportable, and it certainly can be chronic. Many women suffer from chronic bacterial vaginosis. It's embarrassing for them. They have a thick yellow-white discharge with irritation, typically with an odor, and it's difficult to get rid of. The recommendations themselves have not changed as far as we still give the flagell, we give the flagell gel, we give clindamycin cream. However, we do have some more oral medications that we can give, including the clindamycin 300 milligrams orally, BID for 7 days. It's not that expensive. And if you give the ovules, you have to be cautious because they can weaken they have a base that can weaken rubber or latex products, typically like condoms. So they need to wait 72 hours following the ovules before using anything like that. So just keep that in mind. You want to educate your patients as much as possible. And it can also affect a diaphragm as well. Going on to some alternative treatments with bacterial vaginosis is there's a new medicine called the secnodiazole, secnodiazole, 2 grams 1 time. It goes by a trade name of Solasec, and I have not seen it out on the market yet, but it seems to be just as effective either by itself or given in conjunction with some other medications like the vaginal gel with Metrogel, and something to think about. However, when we look at the price for just a person who's coming in with their first time having bacterial vaginosis, a 7-day dosing on GoodRx was about $11 for flagell or metrodiazole. The average price for the secnodiazole was about $300 or a little bit over. The company itself is marketing it for a treatment of trich, but the CDC guidelines are not indicating that as of yet, but you can go on their website and it talks a lot about what the medicine is and what its uses are. So that's just something to consider. It is coming up. Patients may want to start using it, particularly if they have insurance, but for right now, it's going to require a prior authorization, I'm sure. Patients, particularly ones who, are new to your practice, you don't know that much about them, it's a good way to find out more information as long as you're comfortable and they're comfortable. And we recommend the 5 Ps, which is the first one, partners. Are you sexually active and with what genders? The next one is what kind of sex activities do you engage in? Oral, anal, vaginal? Are they with toys? That kind of thing. Did you ever discuss prevention with your partner or partners prior to being sexually active? What are you doing for protection? How often are you using condoms? Very good way to start the dialogue there. Have you ever been tested for HIV or STIs in the past? That's a very important question because there's a lot of co-infections in STIs. And we also know it's been proven that having an STI makes a person more susceptible for HIV. So that's something that we want to be screening for. The other thing we want to do is, are you thinking about having children? What is your pregnancy intention? Are you wanting to prevent now? Are you comfortable getting pregnant and not using any kind of birth control or using condoms? Would you like to discuss pregnancy prevention? So that's just the 5 Ps, and you can pick those up on the CDC website. Very, very easy to access. Also, the American Academy of Family Practitioners, I think, and the American College of Obstetricians and Gynecologists, ACOG, both have real good information on how to do a proper screening. And they're also really good about having questions on how to do different screenings on patients for particular populations. So if I can get to the next slide, I thought I clicked it, maybe not. This could be anyone from adolescents, pregnant women, the LGBTQI community, persons in correctional facilities. And for instance, if you are between the ages of 15 and 24, you're female, the American College of Obstetrics and Gynecology and the CDC recommend that they are screened at least once a year for chlamydia, particularly if they're sexually active. That's very important. Whether or not they choose to tell you they're sexually active is another thing. Their health condition, men who have sex with men and are on PrEP, they may want to be screened for HIV, not only HIV, but also hepatitis A, B, and C. If it is a transgender male with a cervix, they still need to have annual PAPs. If they are living, obviously, in correctional facilities, there is a need to be screened for HIV, syphilis, and the hepatitis. So there's just certain things that you should remember, and the CDC and ACOG have some great resources that you can pick up online for any of that information. Thank you so much, and I hope you've enjoyed all of this. Oh.